somewhere between 30 to 40, have about 1.5 times the risk of having cardiovascular disease when compared with people who have better kidney function. Okay, so this is a slide that feedback. Yeah. Oh, I wonder if somebody can mute their phone. I'm just getting some feedback. Okay. Anyway, so this is a slide. So I can just, sorry, I can just hear myself when I'm talking. This is a slide about different types of cardio-renal syndrome. It's not meant to be diagnostic labels. It's really meant to help us understand a little bit about genesis and pathophysiology. So, for example, the type of cardio-renal syndrome that you and I will see most often will be patients who have chronic heart disease and congestive heart failure, who also have associated kidney disease. And we will see those patients quite often moving into decompensated heart failure. And those episodes require hospital admission. And then, of course, the other patients that we see are patients who have chronic reno-cardiac syndrome. In other words, patients who have chronic kidney disease, but because of their kidney disease, get cardiac disease. And so we'll talk about those three entities. So first of all, just to give you a case presentation, this is a gentleman well known to the Kidney Care Clinic at St. Paul's Hospital. Lovely, actually older than 53 right now, I think, but 53 with dilated that was diagnosed in 2001. At that time, he had a heart function of 15 to 20%, normal being 55. His comorbidities included atrial fibrillation, type 2 diabetes, obesity, hypertension, and peripheral vascular disease. By 2011, so 10 years later, he did quite well for about 10 years, but by 2011, he was starting to decompensate, and at that time, he was on COSAR, so an angiotensin receptor blocker, a beta blocker, reno-cardio, which is an aldosterone blocker, diuretics, and of course Lipitor, metformin, and insulin for his diabetes. His serum creatinine at that time was around 130 to 150 micromoles per liter, so already had some evidence of kidney disease at the time. By August of 2012, so just about a year after he started having more symptoms, he decompensated, requiring hospital admission, and had an acute kidney injury. He was 8 kilograms above his target weight, and his COSAR was stopped so that his kidneys could recover. In September, he had yet another admission to hospital with heart failure. So just really 1 month later, this time he was treated with inotropes, with milrinone and IV diuretics, and then he had dialysis for volume removal at that time as well. November 2012, he once again was admitted to hospital with heart failure. Sorry, I'm still hearing my voice, so if there's anybody who is not muted, if you can mute, that would be great. Okay, anyway, in November, he was readmitted again with heart failure, so 3 admissions in a row, treated with IV furosemide and milrinone again, just to try to increase his cardiac output. And at that time, he had a peritoneal dialysis catheter inserted because the diuretics were not working to effectively remove his volume. By January, he had a left ventricular assist device put in with improvement, and the PD catheter was removed. But then a few months later, he again needed some dialysis to remove extra volume that he had accumulated, and then eventually was stabilized with a creatinine now of about 160. So he now has some chronic kidney disease, presumably as a result of his cardiac disease. He then got a heart transplant in February 2014, And although he needed a few hemodialysis treatments after his surgery, he's now stable and followed by the kidney clinic a few years later with creatinines of around 140 micromoles per liter and is actually doing reasonably well. His chronic kidney disease, therefore, right now is a combination of cardiac disease as well as his diabetic nephropathy. So what this nice gentleman shows us is that when you have heart failure admissions, you have an acute event which leads to a drop in kidney function, followed by another acute event, and so on until you get ongoing decrease in kidney function over time. So just to talk about the pathophysiology, a little bit of cardio-renal syndrome, if you look with me in the middle, you'll see that most of the diagnoses here can affect both the heart and the kidney, which is often the case. So hypertension, diabetes, dyslipidemia, smoking is a big one, obesity. If we follow the heart line for a second and patients get cardiac disease from these diagnoses and heart failure, they then have decreased cardiac output, which leads to, of course, decreased flow into the kidneys. They get more inflammation and fibrosis, kidney dysfunction, which then makes the heart failure worse, because we know that when you have renal dysfunction, we have more uremic toxins, inflammation, anemia, more hypertension, more salt and water retention, and it makes the cycle worse. So if we look at that again, same pathophysiology, but more with a diagram, we can see that if you have less heart dysfunction, the body increases its sympathetic drive, and so you have increased adrenaline, increases its renin-angiotensin-aldosterone system, and you get vasoconstriction with sodium and water retention, which leads to decreased renal perfusion and chronic kidney disease. Once you have kidney disease, then of course everything gets worse. And then in addition to the left heart failure, you have right heart dysfunction, which increases the venous pressure here in the kidneys and decreases GFR just because of the right-sided pressures going up. It's interesting that the heart also tries at the same time to put out some vasodilatory hormones. And we all know that, for example, BNP goes up when patients are in heart failure. And that's an attempt of the heart to try to induce some vasodilation as well as some diuresis. The problem is that these are really not very effective. And so what predominates is this particular cycle here on the left-hand side of your slide. Okay, so decreased cardiac function leads to decreased renal blood flow, decreased GFR, acute ischemia and acute kidney injury, and eventually when you have acute kidney injury on acute kidney injury, you get renal fibrosis and chronic kidney disease, as I showed you with our gentleman, Mr. B. The right-sided heart failure, it also causes acute kidney injury, and there's a lot more in the literature these days about the role of right-sided heart failure causing kidney problems. So you can see here in this picture that if you and I, hopefully, have normal blood pressure, 120/80, when we look at our big vessels like the aorta and the arteries, there's a lot of flow, a lot of perfusion. But when you move into the glomerular capillaries, the flow is down quite a lot. So if you start with a lower mean arterial pressure, as you do with heart failure, you can see that by the time you get to your glomerular capillaries, there's really not a lot of flow. So it's not hard to understand how having heart failure would lead to decreased kidney perfusion. What we also know, though, is that the right-sided heart failure causes just increased interstitial pressure, right? Interstitium of the kidney. So right-sided heart failure is as bad or adds to the left-sided dysfunction. Okay. The sympathetic nervous system is huge, and I think you'll see how we address that in a minute. But basically, the sympathetic nervous system and the renin-angiotensin system cause a lot of renal vasoconstriction and water retention, and then, of course, more cardiac injury because now you're retaining more fluid. So again, we get back to that vicious cycle that we were talking about just a second ago. So our patient, Mr. B, exemplifies an attempt to address each of those pathophysiologic mechanisms with medication. So he was on beta blocker to try to decrease the effect of the sympathetic nervous system. He was on Cozar and spironolactone to try to inhibit his renin-angiotensin aldosterone system. At some point, this poor man required inotropic support and diuretics in the hospital, eventually required ultrafiltration with dialysis, and then also needed a left ventricular assist device as a bridge to transplantation. So if we talk about treatment, the best treatment is actually preventing decompensation of heart failure. And you'll see in just a second that that involves interventions and expertise that we already practice in the kidney care clinic together as a team. And this really requires a village, actually, not that and kidney disease.